Good morning to everybody west of Thunder Bay and good afternoon to the east. Welcome to the conclusion of the Canadian Patient Safety Institute's Human Factors webinar series with our final presentation, Collaborative Spaces and Health Information Technology Design. My name is Christopher Thrall. I am the Communications Officer with CPSI and will be your moderator for the webinar. I would like to welcome you on behalf of our web host, Tricia Swartz, CPSI Patient Safety Improvement Lead, and our technical host, CPSI Project Coordinator, Gina Peck. This webinar will describe the evolving relationship between collaboration and HIT and discuss implications for the design and evaluation of HIT to support collaboration. By the end of this discussion, you'll be able to identify the definition and models of collaborative care delivery, the challenges in HIT design to support collaborative care delivery, and the HIT designed to support collaboration, including usability and workflow implications. It gives me and CPSI inestimable pleasure to introduce our speaker for this webinar, Professor Craig Kuziemsky. Dr. Kuziemsky is a full professor and the University Research Chair in Healthcare Innovation in the Telfer School of Management at the University of Ottawa. He completed his PhD in Health Information Science from the University of Victoria in 2006. Dr. Kuziemsky's research focuses on collaborative healthcare delivery models that lead to better design of information and communication technology. His work has defined the structural aspects necessary to support collaboration, as well as the behavioral and social processes that shape how the structural components work. Dr. Kuziemsky was awarded the University of Ottawa 2013 Young Research Award in Social Sciences and Humanities. He is the current chair of the International Medical Informatics Association Working Group on Organizational and Social Issues. He is the principal investigator for a Natural Sciences and Engineering Research Council of Canada Discovery Grant to study contextual aspects of collaborative teamwork in order to better model and develop supporting technologies. Dr. Kuziemsky will speak for approximately 40 minutes, allowing us 15 minutes at the end for questions and conversation. Please write your questions and comments in the question and answer box or the chat box, and they will be compiled and provided to our speaker at the end of the call. If you run into any IT difficulties, please connect with us in the chat or question and answer box, and we would be happy to assist. Without further ado, CPSI is delighted to welcome our speaker for today, Dr. Craig Kuziemsky.
Thank you very much, Christopher, for that very generous and very nice introduction, and thank everybody for attending. I'm quite honored to get the chance to do the last seminar of the year, and I think it's actually a really nice fit. Initially, the seminar was actually scheduled earlier on the schedule, but due to some conflicting scheduling issues, it got moved. But I think looking at kind of collaboration spaces and how it influences usability and human factors issues, I think will actually be a nicer fit now than it may have been earlier. And in particular, those of you that saw Dr. Elizabeth Brickey's seminar, a month or 2 months ago, it'll actually be a really nice fit with that one, because some of the things I'm going to talk about are going to kind of be a segue from some of the methods and some of the technology-induced errors that Elizabeth talked about. So hopefully you'll get a lot out of this, and I look forward to having a conversation with everybody. So what I'm going to talk about, Christopher sort of introduced this. I'll talk a little bit about collaborative care delivery in general, a bit of a background. What do we know about it, and probably more importantly, what do we don't know about it? From what we don't know about it, I'll then look into challenges in designing technology to support it, because obviously those two are quite interrelated. And then I'll kind of conclude by talking a little bit about, based upon what we don't know and based upon how we think we need to design technology to design and evaluate collaboration, how do we subsequently go about trying to look at technology design? So as a starting point for a background, there's any number of ways that we can look at healthcare delivery and healthcare transformation. I tend to look at kind of our current healthcare delivery paradigm really is one of connectivity and collaboration. We're trying to deal with a lot more chronic diseases which aren't managed in the moment. They're managed over time and space. Patients that, have, more significant illnesses like cancer and even other types of acute illnesses that used to have very short lifespan now have much longer lifespan. So, we need to connect care, and we need to sort of develop collaborative approaches to try to provide care over that entire trajectory. And, all of us on this call probably know that there's been a lot of efforts in trying to re-engineer the healthcare system in order to better deliver care through these new care delivery models like patient-centered care, like collaborative care delivery. And, there's any number of reports that have advocated for it. Certainly in Canada, we had the Romano report and the Kirby report. There was the Healthcare Innovation Working Group from the Premiers of Canada that came out a few years ago. There's a number of reports out of the Institute of Medicine in the United States that have sort of all talked about the need for new approaches for healthcare delivery. And, countries are spending a lot of money to try and do it. And, despite, I think, a lot of really good intentions and despite spending a lot of money, we really still haven't got where we want to get to yet. And, I think the United Kingdom Connecting for Health example is probably one of the better lessons learned, back in September 2011 when they basically pulled the plug on the Connecting for Health project. I think they showed that, money alone really can't buy healthcare connectivity and healthcare transformation. And probably more importantly, technology alone isn't going to get us where we need to go. So as we kind of take a look at, why is collaboration important? Again, as I said earlier, really a lot of what we do, handovers, patient transfers, chronic disease management, team-based care delivery, even moving a patient from the pre-admit unit to the operating room to PACU, these are all collaborative activities. And I think sometimes we underestimate the extent of collaboration that actually takes place in healthcare activities. And, as we try and manage chronic illness and try and, really deliver the benefits of team-based care delivery and patient-centered care, these are really collaborative activities. And in order to get better at team-based care delivery, we really need to understand how collaboration works, as it's really the underpinning of how team-based care delivery works. So just to kind of summarize a little bit of where we are to date, this is kind of how I look at collaborative care delivery and sort of, what I call the collaboration paradigm. And we can look at collaboration using kind of a classic micro, meso, macro type of spectrum. At the micro levels, kind of right here, and we've got a patient that might be interacting with their primary care physician. They might be using an electronic medical record system. They might be using a smartphone app or an Apple Watch to try and input data. If that patient has a chronic illness, possibly they have diabetes or congestive heart failure or something, they're probably going to be managed by a care team, and that's where we start bringing in multiple professionals. So aside from just having a primary care physician, the patient might get care managed by a dietitian. They might have a pharmacist. They'll probably likely have a nurse in there. They could have different types of therapists like physiotherapy or occupational therapy. And then from that team-based or that collaborative care delivery, we generate data, kind of goes into the big data pool in the cloud or in the sky or whatever we want to call it. And then we try and analyze that data. There's a lot of work currently being done on learning health systems, which ultimately tries to then use those learnings to cycle back into both the meso-based care delivery, where we try and improve care delivery by teams, as well as at the micro level, where we try and improve care delivery by, say, individual clinicians and individual patients. And I think as we take a look at this, certainly there's bodies of research that are happening in each of the three streams. So at the micro level, at the meso level, at the macro level. And I think really where the biggest challenge from this slide is trying to connect the two areas because, as I said, technology alone isn't going to transform healthcare delivery into the type of system we want. Algorithms, models, artificial intelligence tools, they don't deliver care. Health systems deliver care, and health systems are really ultimately defined by the people and the processes that work in it. And so I think until we get better at, really embedding some of this artificial intelligence and big data types approaches into care delivery, Enrico Carrera has a very good term. He calls it the last mile problem. So he says, we can analyze data using artificial intelligence approaches, but until we're able to get those learnings into, really embed them in a day-to-day care delivery, we're going to keep suffering from that last mile problem. So that's kind of summarizes where we currently are with this slide. And most of my work really takes place at the meso level because, again, I'm interested in collaboration. So I'm interested in kind of this kind of listing of words right here, how people collaborate, how they communicate, how they learn from each other. But I think just the key lesson is you can't really look at the meso level without understanding what happens at the micro level, because they're interrelated. And you can't really look at the macro level without understanding what happens at the previous two levels. So I'll talk about that a little later on, but just, you know, as I start kind of going through the slides, you may just want to keep this in your mind as a bit of a roadmap as to how collaboration gets laid out. So, you know, what do we know about collaboration? Well, like I said earlier, there's, you know, it's a common objective worldwide. There's probably more reports and commissions on the need for collaboration in healthcare reform than we care to admit. There is a lot of really good research done by people on various aspects of collaboration. So certainly medical education and interprofessional education and collaboration has had a lot of work done it. There's been a lot of, a good body of work done on teamwork. So how do different teams come together? How do different team type of structures get defined? How does care differentiate across different types of teams? So how would, say, a multidisciplinary team differ from an interdisciplinary team? And there's also, you know, been a lot of work on handoffs. And, you know, David Bates, I thought, made a very nice, bold proclamation a couple of years back when he said that really, you know, collaboration and coordination, it's the next big opportunity for informatics. So he kind of acknowledged that we're really not as good at designing health information technology to support collaboration as we should be, and that's where a lot of our effort needs to be. So that's what we know about it. What do we not know about collaboration? Well, you know, we really don't know how to design for it. B.T. Karsh and colleagues, you know, had a really good paper that was out about 8 years ago where they said there's really a lack of, you know, explicit studies on it, and more specifically, a lack of explicit insight on how we design for collaboration. And, you know, one of the good lines out of that paper was, designing health information technology to support collaboration doesn't involve just kind of putting a new interface on an existing system. So, you know, we can't just take an electronic medical record system and tweak the screens and the drop-downs a bit and expect it to do what we want it to do, but rather we really need to explicitly understand the requirements and the needs of people involved in collaborative care delivery. You know, we don't know a lot about the workflow that people engage in when they're involved in collaborative activities. There's a lot of workflow models for individual providers, but what we find is when we try and scale these models up to support collaboration and teamwork, the scaling doesn't tend to work very well. And then the last piece is what I call, you know, the bounding issue. Collaboration is such a broad concept that if I asked everybody on this call, you know, how would you start studying collaboration, or what do you think are the key things we need to focus on to study collaboration, I would probably get as many unique and correct answers as everybody on the call. So really, you know, the bounding issue is, where do we start? You know, how do we put boxes around things that we need to know or that we need to try to better understand in trying to start modeling and start improving design of technology to support collaborative care delivery? So as we start thinking about technology design for collaboration, so trying to address some of those issues on the previous slide, you know, how do we start thinking about interfaces and how do we start thinking about workflows? You know, there's a few challenges and a few things we need to think of. One is that, you know, again, healthcare collaboration is largely an unbounded process. It's got a lot of aspects that are unstructured. Ad hoc things need to happen. So we need to understand how to co-construct those events with technology. You know, anytime you put together diverse human beings, patients, providers, administrators, technology, and processes, and you try to get them to work together, there's always going to be challenges. And, you know, I think the extent of the challenge of designing for collaboration can really be reflected by some of the research that's been done to date. So Madhu Reddy and colleagues did an interesting study back in, you know, about 10 years ago, 2008, where they just looked at generic health information systems like order entry systems and electronic health record systems, and they found that even though these systems weren't designed explicitly to support collaboration, they were actually able to provide some collaborative support. So it was kind of a, you know, a bit of an unintended consequence, a good unintended consequence. However, you know, a year before that, David Dorr from Oregon Health Sciences University and group they did a similar type of study where they said electronic health record systems are typically designed for individual users and don't really support collaboration. So again, even in the medical informatics community, there seems to be a bit of disparity or a bit of disagreement with respect to how technology can support collaboration. So as we think about some of the challenges in designing for collaboration, obviously if we try and automate work processes or try and develop workflows without understanding the context of how we're going to actually, what we're trying to automate, we're going to end up with technology-induced errors. And again, Elizabeth Brickey did a really nice seminar on how that happens a couple of months ago. Jeff Braithwaite had a nice comment where he said that if we just try to restructure, so again, if we try to organize for collaboration, we don't really have a clear vision of where we want to get to, we're going to move the pieces around, but we're probably not going to have a very successful outcome. Enrico Coiera sort of picked up on that and said that one of the challenges is healthcare tends to sit in what he calls a state of inertia. So even though we adopt some new practices, we don't fully embrace the new practices. And then what happens a lot of times is we end up with somewhat dangerous hybrids of paper and electronic, or we end up with dangerous hybrids of the new and the old, and those can lead to a bit of unpredictable types of outcomes. And then finally, if we think about the evaluation of collaboration, there really aren't good metrics for how we measure collaboration and probably more importantly, how we actually measure its development. Because again, collaboration isn't something that just happens overnight. It's not like you just put people together and they start collaborating. There's going to be some sort of a development process, and we need to better design metrics that allow us to sort of measure, the extent of collaboration within a care team or within an operating room team or within a patient care team or whatever, and then subsequently how that team gets better at collaboration as they kind of move down the continuum. So those are some of the challenges in designing for collaboration, and then ultimately, because of our inability to address some of the issues on the previous slide, not having proper evaluation metrics, really not having proper requirements for what collaboration entails and how we need technology to support it, we end up with unintended consequences. So we end up with consequences such as patient safety issues. We end up with human factor issues, which end up being quite common. And these subsequently end up really being a barrier to what we're trying to achieve. And again, there's, a whole body of literature on unintended consequences, which I'm not going to go into today, but, Joan Ashmarkberg and Enrico Coiera sort of had a really nice framing of it back in 2004. Ross Capell and colleagues have done a lot of work on it. And again, Elizabeth Brickey and both her and Andre Krishnarik have done a lot of work on sort of usability unintended consequences that emerge post-technology implementation. And just as a couple of practical examples, here's just a couple of screenshots from some newspapers over the last couple of years. So on Vancouver Island a couple of years ago, they implemented a Cerner electronic medical record system. They weren't using it very long, and this was kind of the front page of the Vancouver Sun, saying the electronic health record system was unsafe, needed to be shut down. As just another example from, the EHR Intelligence kind of blog website, had a pretty good article a few years back, basically said, why do so many EHR implementations fail, where they talked about a number of, these unintended consequences that have emerged across different types of implementation. So, we know there's a problem. How do we subsequently go about trying to address it? Well, to kind of summarize the introduction part of the slide, I think the biggest system design challenge in modern healthcare is that on one hand, medicine, so you think about precision medicine and you think about advancements in, pharmaceuticals and advancements in surgical techniques and advancement in chemotherapies, we've made really good advances in medical knowledge, but what these advances have done is they've led to complex patients that require complex care delivery, such as collaborative care. And I think in some ways we're the victim of our own success in that we, medical knowledge has created these complex patients, but the health system that we have in place, and more specifically really the technology that we have in place within the health system, it's not really designed to support that complex need. So we kind of have this, complex patient and complex care delivery, and we need to somehow find the the equivalent complex health information technology and complex collaborative type models in order to support it. So that kind of leads into the main part of both my research and what I'm going to talk about today is, well, how do we design health information technology for collaborative care delivery? Well, the first thing we need to do is kind of a couple of things I'm going to talk about. I'll sort of talk about terminology first, and then I'll get into methods in a little bit. But really, the first thing we need to do is acknowledge, what collaboration really is. So Madhu Reddy and his PhD student, Elizabeth Eakey, and myself, we did a systematic review on collaboration and health information technology a few years back, just because, nobody had done such a review, and we wanted to see what the state of the science was with respect to collaboration and health information technology. And, what we found was there was a lot of papers that talked about collaboration and technology, or they talked about collaboration and workflow, but very few people actually defined collaboration. And again, as I kind of said earlier, without knowing a definition of collaboration, if I asked everybody on this call to define collaboration for me, I would probably get a lot of varying definitions. So what we did was kind of drawing upon definitions we were able to find, this is what we tried to come up with as a definition for collaboration. So there's some sort of engagement, it can be planned, it can be unplanned, between either individuals, teams of individuals, it can be in person, it can also be asynchronous, mediated by technology. You've got some sort of information exchange that's happening, and it can be, explicit or implicit exchange. And, the piece in red is really the key part about the definition, because this is what separates collaboration from other terms like coordination or communication. Collaboration is really about developing a shared understanding. So if we're trying to work together on patient care, we may not have a shared understanding of how we should ultimately manage that patient's care or treat that patient, but through the process of collaboration, we come up with that shared understanding. And that's really what differentiates, again, collaboration from, say, coordination, because coordination is connecting people, but it's not necessarily facilitating that shared understanding, which is a key part in order to be collaborative. So, if you think, an example of a coordinative technology can be something as simple as like Microsoft Outlook. If we send out a meeting request to everybody, you all know to come into the chat today at noon. When it starts, you've all accepted it. We've kind of coordinated all of our activities at that particular time, but that doesn't necessarily mean we're collaborating. We've just coordinated our activities, so we're all going to be in the same time and space for a particular period. So this is really the key piece, this kind of shared understanding is really the key piece that defines collaboration from some of the work that we've done. So once we set up, once we established the terminology, the next thing we really wanted to do was, get back to that bounding problem that I talked about earlier, and we wanted to try and figure out, okay, now that we know what collaboration is, we've got a working definition of it, how do we go about ultimately trying to figure out how to study collaboration in different settings? So Enrico Coiera's kind of, for several years, he's really described, and he does a very nice job of doing it, describe the importance of studying what he calls spaces where people and processes interact. So these spaces, again, it's almost like putting boxes around where activities happen to sort of try to find a way to facilitate better studying and better understanding of what happens within these boxes. So aside from the need to kind of understand the spaces where collaboration occurs, we also need to understand, what is the context within these different boxes, because again, we know that collaboration, we know that care delivery in its element is diverse, and thus collaboration is going to be similarly diverse. So even though we've established what collaboration is, we then need to try to figure out how collaboration differs across these different spaces. And then really, ultimately, we need to focus on, what are the people, what are the process, what are the tools that try to define collaborative healthcare delivery, because those then really become the requirements for how we subsequently go about designing technology to try to support collaboration. So what we did was in that systematic review that I talked about earlier is we looked through all the papers. We came up with what we call the collaboration space model, because again, that was our way of trying to provide some bounding to the existing studies of collaboration. We looked at all these papers in our systematic review, certainly the ones that kind of made our final criteria for the review. And as we looked at it, we wanted to see how are people studying collaboration? What processes are they looking at? What contacts are they looking at? And then we really wanted to use that, almost, again, as a bit of a method or a model that other people could take to try to study collaboration across different settings. And this is what we came up with. This is what we kind of define as our collaboration space model. So first of all, in the upper left quadrant, we've got the technology. So we've got, the patient, are we looking at technology for a patient? Are we looking at technology for providers? Are trying to connect both of them? What's the functionality that the technology provides? So does it work synchronously? Does it work asynchronously? Things along that line. If we kind of move to the right, we then looked at the context. So, what are the settings where collaboration is being used? What are the different user groups? So is it an inpatient type of a collaborative technology? Is it a community collaborative technology? Is it being used in, a specific part of the hospital, like the intensive care unit or the operating room, or is it a more broader type of collaborative system? As we then looked at the processes, this is where we tried to look at the different workflows. We looked at, how does technology that's currently being used try to connect providers across different spaces, how are workflows defined, and probably more importantly, how are workflows ultimately integrated, given that collaboration is about different spheres of professionals, and thus workflows are going to have a certain degree of, give and take. And then finally, for the outcomes, I think one of the real aha moments that we had in doing a systematic review was that you don't collaborate just for the sake of collaboration. I mean, obviously, better patient care and sort of, provider quality of life and workplace quality of life or outcomes we want to achieve. But as we looked at papers that talked about collaboration, the two main outcomes that we came up with, it's really about maintaining awareness. So again, given that a lot of collaboration happens asynchronously, it's about knowing what your care team members are doing, what they're not doing, who's assigned to what task and who's not assigned to what task and things like that. And then it's also about trying to establish common ground, because I'll talk about common ground in a little bit, but common ground is really that common knowledge that enables us to work together. So it's my way of knowing what your skill sets are and what other skill sets are to make sure that as we start assigning tasks, that I don't assign you to something that you're, either don't want to do or aren't able to do. So these are the outcomes that we came up with respect to what people try to achieve through collaborative activities. So then kind of the research on collaboration spaces, so now we've kind of got the terminology set up, I'll talk a little bit about the research that I've done on collaboration and kind of how the SIS review model that I just looked at, it kind of really serves as a method for studying collaboration. And as I kind of started developing my research track on collaboration, I started to look at it in two levels, and I kind of borrowed this from a paper by Matthew Press and group, where they said that if you think about, bringing about healthcare reform or healthcare change, there's really two things you need to look at. You need to look at the structure, so kind of do you have the right pieces in place? And then you also need to look at the behavior. So again, the behavior really becomes some of those collaborative outcomes like awareness and common ground, contextual variation from the previous slide. It really gets at, okay, if now that we've got pieces in place, but are the pieces going to work in the way that we want? And that's where the behavior gets at. So I'll kind of talk about some of my research, along the lines of looking at both the structure and the behavior. So just as an example, it's kind of some recent work that I've done. This is kind of a model for what we call connectivity for social information system design in healthcare that myself and some of my colleagues came up with a couple of years ago. And it's really our first model where we tried to articulate that structural behavioral type model. So, the structure kind of at the top here. Marker there. So kind of the structure, right there. We basically said, okay, you've got people, you've got processes, and you've got technology. Those are what we envision is the moving parts of the system. And then as we looked at behaviors, we looked at, okay, what are things that then impact or would impact people's abilities to, conduct processes? And, this gets at things like, user-driven design flexibility, making sure interfaces are suitable for people. It looks at things like workflows. It looks at the processes they do, even looks at things like data standards and interoperability standards to make sure that people are able to get access to the data and the information that they ultimately need. And then what we tried to do at the bottom, and this is very much still a work in progress, so if anybody has any kind of long-term suggestions, we're quite happy to hear it. What we were trying to come up with is what we call kind of the social information system connectivity factor. We were trying to come up with some sort of a coefficient that basically, would give some kind of an indication of how complex a particular scenario is. So by going in, looking at workflows, looking at standards, looking at what people do, can we get some kind of a ranking or some kind of a number that would at least allow us to look at different variations in, really in collaboration based upon the complexity of factors inherent in a particular place. So what I'll do is I'll kind of just go back a little bit and look at and just describe briefly some of the research that I've done on structures and behaviors. So as I said in the previous slide, structures, this is the ecosystem where collaboration takes place. It's really the moving parts. This is where we kind of define the workflow. We look at the workflows that are being done, we look at the processes, we look at the people, and we try and really, take inventory. What are all the parts in the system? When I lecture to my students, even when I do talks all over, I usually use the Lego analogy. I'm sorry, I can't do animation on the slide, so the Lego pieces are actually supposed to kind of come together in a nice manner, but you get a static Lego picture. But, to me, the collaboration structures are like Lego. It's a whole bunch of pieces, and again, there's, probably no two collaboration spaces that are alike, and thus, when you start modeling a collaboration space, it's almost like dumping a bucket of Lego on the table. You've got green pieces, you've got yellow pieces, you've got blue pieces, and how the pieces fit together really needs to be tailored to the specific situation that you're in. Just as a quick example of some of the work that we've done, so this is some of the work that myself and my colleagues have done in trying to model collaboration structures. So this is an example of a palliative care pain management workflow that we did in conjunction with some colleagues in Ottawa. And, don't get bogged down in the details, but really what you just want to look at in, let me try to get the pen back, what you really want to look at in this, what you really want to look at in this is just there's a whole bunch of pieces. We've got kind of a care team here. We've got a patient here. We've got a whole bunch of providers. Providers have different workflows. They've got different preferences on what they want to do. And ultimately, as all these pieces start laying out, we end up with a nice collaborative environment. And what you really want to take away from this is, this is kind of a perfect model of collaboration for this particular context. And it really depends upon all these arrows and all these boxes working in the manner in which they're laid out. Now, if you think about structures and collaboration, one of the things that you want to sort of take away is that there's different kind of levels of granularity we can look at. So this is almost like a meso-level model. It's got the pieces, but there's no one assigned to them specifically. This is kind of almost like the city version of a Google map. If we then drill down on that map, say down to a street version, this is another example of some work I've done on collaborative context using a perioperative example of a perioperative information system and trying to look at how collaboration works or how collaboration happens across the entire perioperative spectrum. And what Andre Kushnerik and I did a few years back is we were interested in how usability issues might differentiate across the different parts of the perioperative spectrum. And what this really shows is that, the blue kind of circle kind of right here on the top, it kind of shows how we move across the areas. And even though within each perioperative area, you've got, they all do data entry, they all do data retrieval, there was a lot of differences in how data was entered depending on whether you were in, the same-day admit unit or the operating room or the post-anesthesia care unit. There was differences in how data was retrieved, again, depending where you were in these particular areas. And really the big kind of aha moment that we got out of this study was that collaboration, even though it's a group activity, it's conducted by a number of individuals. And what we found was if an individual was having human factor or usability issues, let's say, at this point in the collaborative spectrum, again, recognizing this is an entire spectrum. So if somebody has usability issues here, those issues are going to keep trickling and they're going to keep snowballing. So if I make a data entry error here, that error will still appear here, and it will still appear here, and it will still appear here. And in fact, depending on how significant the data entry error is, it may actually cause patient safety or other types of unintended consequences as we move down the spectrum. So the real takeaway from this study was that even though collaboration is about designing for collaborative teams, we really need to still pay attention to individual usability and individual human factor type issues. So as we move off of structures and I talk about behaviors, I find behaviors a lot more interesting because, again, this is really how people, processes, and technologies, how they engage within those structures. So if you go back to that kind of perfect ontological model of the cancer pain management workflow that I showed you, and as I said, that's a perfect model of how collaboration should work. Behaviors, they give us the information as to why that didn't work as perfectly as we want. And there's really two aspects in behavior that I look at. The first one is, what I call the rules of engagement. So again, as people start collaborating, as those pieces start moving together in the structure, what are the rules of engagement for who does what? How do I know that it's my turn to update the patient chart? Or if there's a change in the patient status, how do I know that it's my turn or somebody else's turn to update the rest of the team with respect to that particular change in status? So behaviors give us, the rules of engagement for how collaboration works. And then the second piece that kind of behavioral aspects of the space give us is what I call the individual collaborative interchange, because one of the, at least what I've seen, one of the biggest challenges in working collaboratively is, again, you're trying to get people that have maybe largely worked as individuals to all of a sudden work as a team. And even though collaboration is a joint activity, the movement from individual to collaborative activities, sometimes it can be a bit of a challenge. People may not appreciate having to work in teams. People may have to change what they do in order to work as teams. They may have to enter different data, or they might have to enter more data, or they might have to access more data. And these, interchange activities can sometimes be challenging. So going back to the previous slide where I kind of showed the operating room structure, really that's an example of where in order to work well collaboratively, we really need to make sure that all the individuals move across that interchange appropriately. Otherwise, we're probably going to have individual errors that end up snowballing into collaborative errors. And just to kind of go briefly through some of the work that I've done. So in terms of looking at rules of engagement, a lot of my work over the last, certainly over the last 8-9 years, has been looking at common ground. Common ground has kind of been acknowledged in health IT literature for a while, again, really being that common knowledge that people need to know in order to work together. But what myself and my colleagues, and particularly my grad students like Alex Cornett, who did a really nice thesis on common ground, we wanted to try and look at specific types of common ground. So not just saying a collaborative team needs common ground, but what we tried to do was unpack different types of common ground. So, we found that, people need to know how to use technology to make sure that everybody uses it consistently. Again, if if one individual in a team of 5 has human factor or usability issues related to technology, that one individual is probably going to cause data entry and retrieval issues for the rest of the team. People need to know about access to information. As you think about collaboration, I think one of the biggest challenges, a lot of communication practices, they're still informal. Certainly we use formal documents and tools like electronic health records, but a lot of it still happens in hallway conversations and kind of happens off the chart. So how do we document some of that? We need to look at things like process common ground. So again, making sure everybody has common knowledge and common agreement about how processes are done. And then finally, we need to know about the different personnel we're working with. So as we start assigning collaborators and team members to tasks and roles, we need to make sure we know what people can and cannot do. And then just kind of my more recent work piggybacks on the work on Common Ground that I just talked about, in that one of the things that my colleague Tracy O'Sullivan and myself are quite interested in is how Common Ground develops over time. Because again, as I said earlier, collaboration isn't something that just happens. Collaboration develops. You don't just put people together and they start collaborating. Collaboration and subsequently the outcomes we want to measure in it, like Common Ground, they're dynamic, and a lot of times people they'll start coordinating. They'll develop trust. As they develop trust, they'll start cooperating. And then finally, as trust and cooperation start forming, then people start actually becoming, a lot more collaborative in the activities and the work they do. So again, Common Ground is really a dynamic, evolving activity. And what we've been trying to come up with is what we call the Common Ground development cycle that hopefully identifies how Common Ground develops and tries to identify some of those metrics that we can use to try and look at how well it's developing. And then the last thing I'll just talk about really briefly is just that individual collaborative interchange that I talked about earlier. Basically that, individual behavior may need to change to support collaboration. And, if you don't really nurture and involve individuals to the extent they need to be involved in trying to develop collaborative initiatives, individual issues like usability issues or safety issues, they're going to scale up to collaborative issues and you're going to have a bigger problem. And a key part of doing that is really the notion of trade-offs. Joan Ash and colleagues have done some good work on trade-offs. So has Ross Capel and some of his colleagues, where they said, we know that when people have to collaborate, you're going to have to do some things differently than you did as an individual. Some of them are going to like, some of them are not going to like. And these trade-offs, you need to acknowledge them, and you really need to discuss them before, technology gets designed and implemented. You need to tell people what's going to change and why it's going to change, and hopefully, you can convince them that, well, okay, you really need this feature, so we'll make sure you keep it, but at that, at the cost of that, are you willing to then give up another feature? So again, it's almost like a negotiation. So just to kind of wrap up with a bit of a discussion, as you think about designing technology for collaboration, again, going back to what I said earlier, it's not about technology, it's not about deep learning, it's not about AI, it's a social task. It's got engineering implications, but if you don't get the sociality part of the task right, the engineering won't work. And, really what we tried to do with the collaboration space model was really give a better understanding of collaboration in different contexts, the spaces that shape it, so we can try to make sure that as we design technology, it's suitable for task at hand. And kind of just, further to that, if you think about technology and collaboration, I think about Twitter and you think about Facebook and these types of tools, there's not a lot that we can't do to support collaboration. In fact, especially in healthcare, I would probably argue that I think the collaborative processes that people engage in aren't necessarily at the level of technology. So it's not about just designing faster, better technology. We need to make sure that we help people and nurture people to really establish collaborative competencies, within people. So, we really need to focus on people. And again, we put in technology, it's disruptive, and we really need to sort of figure out how to bound, how we study collaboration, and subsequently how we design and evaluate for it. So again, we really need to sort of, hopefully try and take what we've started to develop in order to develop some evidence on how to design collaborative spaces in different contexts. So a lot of the work that we found in the review was actually in acute care settings, so that I think there's a real need for understanding collaboration, certainly in community settings and, patient homes, really outside acute care centers. As we think about, designing technology for collaboration, again, it goes beyond electronic health record or order entry systems. It's not just tweaking what we currently have. It's probably going to be a pretty substantial redesign. And then kind of the last thing is just, that individual collaborative interchange. I don't think it's possible to sort of engage in collaboration without changing what individuals do. It may be changing standards, it may be changing terminologies, It may be changing workflows and the work practices people do, and we really need to reconcile these changes, have conversations about them, before we try and change them. Again, like I said earlier, a lot of these, I think they come down to a negotiation and a trade-off, and, we really need to have upfront, open discussions about them. And just, as a final thought, in all the work that I've done, I know there's a lot of work on unintended consequences, and, I'm not sure we can ever possibly really eliminate all unintended consequences. I think it's impossible to automate a complex setting like healthcare without having something happen that we didn't anticipate. And I think all we can really hope to do is, through, the work that kind of myself and I think probably everybody else on this call and the previous webinars have showed, is that it's really about trying to be proactive. The better we can understand what these factors are, the better we can at least try and manage the unintended consequences, even if we can't completely get rid of them. So that is kind of the end of my talk, and I'm happy to answer any questions for the time period we've got left. And if anybody would like to follow up offline, these are my contact information.
Beautiful. Thank you so much, Craig. That was a terrific presentation. I actually was really enjoying the way you kept bringing it back to the people. The people who are using this technology are really what's going to be the efficiency and effectiveness of it. So I do have a few questions that came from the floor, so bear with me on this one.
Okay.
Due to the complexity you noted about collaboration spaces being unique, have you seen examples where health information technology has been utilized in interprofessional education environments? And is there a focus on this type of HIT usage or testing to either embed that HIT early on in education to support collaboration in those interprofessional teams, or to test the technology to ensure that it works with the teams?
Yeah, that's an excellent question. There certainly is I think a grassroots initiative to, I think part of it really comes down to, beyond the technology, I think really starting at the training levels. As we train providers, nurses, physicians, therapists, pharmacists, I think, really training people to think and work collaboratively at that level is the starting point. And certainly, there's a lot of, certainly in Ottawa, there's DIME, the Division of Medical Innovation, that's trying to look at a lot of the work that's done that. Some of my colleagues out there, like Doug Archibald, have actually done some really good work at how do we integrate medical education type of approaches to sort of have these education approaches work hand in hand or side by side with how we put technology in and how we, put in new workflows and things like that. So, I think that's really what we need to try to focus on from that end. I'm not sure if that totally answers your question, but.
Absolutely, absolutely. Thanks so much for that, Craig. I do have another question that came in. You touched very briefly on potential unintended consequences of technology, and I know you came back to it at the end as well. But those unintended consequences of technology in healthcare, exploring that idea, how does artificial intelligence in health technology, such as assisted decision-making software and tools such as that, impact collaboration? Can there be conflict or ethical issues that are raised by such technology if for impacting collaboration team performance?
Yeah, and again, I think the AI is a conversation that we're going to have for a long time.
For sure.
The challenge with AI is, AI and machine learning and, even going back to classic data mining approaches, they're based on, okay, you've got a training set. We train this algorithm using a training set, and then we apply it to a real set. So it's only going to find what it knows to look for. And I think one of the big challenges with AI is that, if it's not trained to look for something, it's not going to find it. And I think as healthcare, moves through processes and as care delivery gets provided, new things happen that AI algorithms are just going to miss because they weren't trained for that. So, I think really part of connecting AI, if you go back to that really early slide where I had the micro, meso, macro, again, it's really trying to, to use Enrico Carrera's term again, really deal with that last mile problem. How do we better bridge what AI is looking for and trying to find with the frontline clinical practice? If you sort of follow the challenges that IBM Watson had, where MD Anderson Medical Center, about 5 years ago, paid a lot of money for Watson to sort of thinking it was going to be a kind of a savior for cancer diagnosis. And, you know, they pulled the plug on it just about a year ago, about this time last year, just because they found it wasn't achieving the outcomes that they had hoped. And again, that was really because, again, you know, Watson has a very structured way of trying to problem solve, and you can't have a, you know, more of a prescriptive problem solving in a really diverse, complex, adaptive system like healthcare, because again, things are going to happen that you didn't foresee.
Gotcha. Well, thank you for that. I guess part two of that question is, are there any other unintended consequences that we should be wary of?
You know, if you look at, you know, certainly, you know, Elizabeth Brickey's work on it, and I mean, Joe Nash and colleagues from Oregon Health Sciences University were kind of the first real group that specifically focused on unintended consequences. I think we're actually pretty good at developing or identifying what they are. And, you know, there's any number of taxonomies on, you know, unintended consequences at different levels. I think the key is really trying to figure out, okay, how do we really study and understand the context and the circumstances where these unintended consequences arise? And I think, you know, just further to that, one of the key needs, I think, is we need to look at these unintended consequences again, I think using a bit more of a systems model, because we're pretty good at, you know, saying they occur. There's even studies where they've actually tried to quantitate them, but, you know, I don't think an unintended consequence just you know, we measure it in the moment, but it's far more likely that the presence of that unintended consequence probably had a bit of an upstream, downstream trajectory. So, you know, we really need to, I think, get better at the trail of trying to figure out where that unintended consequence came from, and how do we then make sure that the pieces that led to it are dealt with. You know, it's not really managing the consequence, it's managing all the pieces that enable that unintended consequence to happen.
For sure, and you're building a learning system that way as well. So
absolutely, yeah.
Good. Question 3 from the floor. You spoke about research that looked at person interface with technology based on workflow. So building on that concept, in your work, have you found or conducted studies that demonstrate what different care providers need from HIT in order to be successful in their roles? For example, physicians need different tools.
I've done that, and there's also some colleagues that have done, you know, quite a bit of work on that. And, you know, I think some of, you know, that's kind of a loaded question, because that could probably be research for the rest of my career, but so as you think about collaboration, you know, when I was doing the perioperative study, I can give you an example in that. You know, so what they were building was a corporate perioperative system kind of used across different hospitals and across different areas. And as part of that study, I spent time basically with every user group. So I spent time with the nurses in the pre-admit unit. I spent time in the operating room with the actual anesthetists who were using it during surgery. And, you know, I think those types of studies, like those ethnographic type studies, I really think that is the way that you have to get at individual user needs, because until, you know, when we train people, a lot of times, you know, we take them into a room and we give them training on an interface, we give them training on how to use the system, but until you actually see it in practice, again, things are probably going to happen that you don't anticipate. So, you know, using, you know, anesthetists as an example, one of the really key things that I learned was, okay, you know, they liked the system. The system was quite usable. They said when they got training on it, it worked really well. But then if you go into the OR, all of a sudden it's a more complex environment because they're entering data on the patient. But they've also got, obviously, the patient on the surgical table who they're trying to administer anesthesia gases and monitor different flow levels. They're trying to, you know, give medications and things like that intravenously to the patient. So even though the system actually worked quite well, the complexity of the context or the complexity of the setting made the use of that system a lot more complicated. So, you know, it's not a matter of just looking at how users interface with the system. It's also looking at that broader setting or that context where the system is being used.
For sure. I guess when they are using those different contexts and different actual tools out of the HIT, does that impact their collaboration as a team? Like, is the HIT going to be weighted more towards one or the other, physicians versus nurses versus speech therapists, or in your example, anesthesiologists?
You know, in theory, you hope not. Like, you hope that, you know, the way the system supports collaboration should be somewhat balance. But again, in reality, you know, achieving that type of balance probably doesn't happen. And again, you know, that's where some of the trade-off discussion has to happen, given that, you know, as we sort of try to automate that entire collaborative spectrum, there probably are people within that spectrum that may have a more weighted or a more heavier workflow than others.
Gotcha. Thanks so much for that, Craig. And I do have one final question. I'm just watching the clock here. So the speaker said, great presentation, by the way, and trade-offs are a real negotiation. Is there more impetus to push collaboration, EHR innovation, perhaps in specialty areas such as MH or OP clinics, ED, where care is not as historically siloed?
Yeah, that's an interesting question. You know, I haven't looked at that specifically, but you know, you would think that, you know, in theory, I mean, EDs are typically very good examples of, you know, where collaboration tends to work quite well. I wouldn't say that I've actually seen, you know, more of an impetus to push collaborative technologies in those specialty areas, because I think, you know, the fact they collaborate quite well, in reality, I think you're probably actually seeing more systems being pushed in areas, say, like community care, or, you know, to use as a kind of a facilitator for patient transfers between, say, acute care settings and the community. I think where collaboration probably actually doesn't work as well.
Okay.
Or between primary care and, say, you know, surgical or tertiary care.
Okay. Is this another NSERC research project potentially?
That could be a very good NSERC research.
Perfect. All right. Well, thank you so much then, Craig. Those are all the questions that came from the floor. So we are going to invite everybody as well to see that we're at time. And thank you very much for sharing your time and expertise. And thank all of you for taking the time to attend. We know how busy your day is, and we really appreciate you choosing to spend time here with the Canadian Patient Safety Institute. So please visit our website for a taped version of the presentation today and sign up. There's actually a Knowledge Translation and Implementation Science webinar coming up on May 30th, where we will welcome Drs. Justin Presso and Andrea Patey to provide concrete approaches for identifying barriers and enablers. If you wish to sign up for this upcoming webinar, or if you want to continue the conversation started in this discussion, please feel free to send us an email. We'll forward your comments and any questions you may have that were unaddressed on to Professor Kuziemsky. You should all receive Gina Peck's follow-up thank you email in your inbox shortly, and you can respond to that. So have a wonderful day. Thank you again, Craig. That was a fantastic presentation, and we had some great chat from the floor. So,
yeah, and thank you, Christopher, for doing the facilitation, and especially thanks to Gina Peck for kind of doing all the pre-setup and doing the walkthrough with me, so I didn't have any technical issues.
Oh, Gina is an absolute godsend to us, and Tricia Swartz on the question emceeing. It's been a fantastic team effort, and thank you again for joining us today, Craig.
All right. Thank you, everybody, for attending, too.
All right. You take care.
Thank you.